Hi, everyone. I'm Sarah Warniak with Immunize Colorado. I'm the program director. Welcome to our webinar titled Addressing Parents' Concerns and Questions About Vaccines for Children in 2026, featuring Dr. Jennifer Reich. All right, a little bit of housekeeping. Webinar attendees are going to be automatically muted for the presentation. If you have difficulties or questions, please put them in the chat box. You should be able to chat with hosts if you have questions. And then, of course, we have a Q&A box at the bottom. We'll be conducting Q&A at the end of the presentation. So please put your questions in the Q&A box. After the webinar, we'll be sharing a post-event evaluation. It'll also be up during the Q&A. So if you could please fill that out, that would be wonderful. And then the recording and slides will be available on the Immunize Colorado website within 1 week of this presentation. We are Immunize Colorado. We're formerly the Colorado Children's Immunization Coalition. We're a statewide 501c3 nonprofit that serves to protect Colorado families, schools, and communities from vaccine-preventable diseases. Oh, I lost my slides. Sorry about that. There we go. All right. Sorry, I'm having some technical difficulties. Please hold. Alrighty. A few announcements on our end. We have an upcoming Western Regional Summit on HPV. It's online May 20th from 12 to 2 p.m. There's a description on this slide. I'm not going to read the entire thing. The QR code on the screen will take you to the registration. It's essentially celebrating the 20 years of the HPV vaccine. So please join us. Other happenings at Immunize Colorado. We have a motivational interviewing training that we have slots open for. So if you or your organization are interested in hosting a motivational interviewing training, we would love to come to you. This is in person typically, but we can also offer virtual options. It's a 2-hour highly interactive training where you learn best practices in talking to parents about vaccines. So very relevant to our webinar today. If you would like to schedule one, please email me. My email's on the screen and will be in the chat. We also have an open opportunity for drop-ins if you know of, like, if you're a single person and you just want to come experience the training. That's on June 19th from 8 to 10 a.m. at Prodigy Coffee House, the one on 4500 Broadway. And you can sign up at the QR code on your screen. And then we also have an AmeriCorps Vista program. We're recruiting members for full-time public health related Vista positions. If you know somebody who might be interested, please email Bennett and I. His email is on the screen and will be in the chat shortly. All right, and without further ado, I would like to introduce Dr. Jennifer Reich. So Dr. Reich is a professor of sociology and director of university honors at the University of Colorado, Denver. Her research examines how individuals and families weigh information and strategize their interactions with state and service providers in the context of public policy, particularly as they relate to healthcare and welfare. She is the author of 2 award-winning books, one titled Calling the Shots, Why Parents Reject Vaccines, and another titled Fixing Families, Parents, Power, and the Child Welfare System, as well as dozens of articles and book chapters that explore immunization, reproductive health, welfare, multiracial families, and the politics of healthcare. Her work has been featured in countless media outlets, including the New York Times, Washington Post, NPR, Vox, Newsweek, and very cool, on the Netflix show Bill Nye Saves the World. So without further ado, I will turn things over to Dr. Reich.
Thanks, Sarah. Thanks so much for having me. And thanks to all of you who are spending what's likely your lunch break with me today talking about it. Let me just pull up my slides and we will jump right in, maybe. All right, let's get started. So So I just wanted to start by acknowledging, like, I don't have any conflicts of interest. I don't take funding for my research for the most part. Um, but I do feel like I could disclose other things that we're not usually asked to disclose. I'm a sociologist, not a physician. And what I'm most interested in is how people form meaning and make decisions in their lives. I'm less interested in questions of whether they're right or wrong or scientifically true or untrue. And so you'll see that coming through today. I also acknowledge that I'm a parent who's made my own vaccine decisions for my own children. And I am married to a pediatrician who works in hospitals. And so I also have like a different perception, I think, of the stakes of the conversation. And that informs the way I ask these questions. I think it's often worthwhile just highlighting that we sometimes, when we talk about vaccine preventable diseases before vaccines, we typically think of a story of high rates of child death that we saw uh, throughout the country, throughout the world, and the ways that that really created a sense of desperation for solutions to protect children. Out of that, we can look historically and see the ways that we have what social scientists have called the vaccine narrative. We sort of came with this story that vaccines are always safe, always necessary, always effective. We glossed over, I think, any negative experiences of vaccines because it was such a miracle to have a solution. And we had spokespeople ranging from Elvis to Marilyn Monroe. To C3PO, right, promoting this in a way where vaccines became a logical decision for parents who love their children. And then that vaccine narrative really informed the way we talked about people's healthcare. What we know today, though, and this started in the 1980s, is that that vaccine narrative is really broken down. The idea that vaccines are always safe, always necessary, and always effective is no longer common sense. And so, what I want to do today then is really think through with you why vaccines might be important as a continuing community strategy, and also the ways that since the 1980s and accelerating rapidly, it feels, we have a series of cultural ideologies that have really eroded support for collective strategies in favor of focusing on individual ones when it comes to healthcare and how that shapes vaccine conversations. And I want to think through with you how this might shape the discussions of vaccines that you encounter in your work and in your experiences, and then make sure we have some time to think about individual vaccines, and then what tools might help in terms of how you can move forward most effectively. So, just as a quick reminder, when we talk about vaccines as a powerful tool for community health, I think it's really important just to be really clear what we mean by that. So, if you think about this diagram and you picture that the people who are colored red are infected with a vaccine preventable disease, and that the people who are blue are unimmunized for some reason. Now, that reason might be choice, but it could also be that they're too young to be immunized. It could be that they are experiencing a health condition that makes them a bad candidate. They could have had immune suppression that's erased a lot of their immune memory. They could have a religious reason to object to vaccines. They could be older and have lost immune memory over time. There's a variety of reasons people are vulnerable. But we know that there'll never be a world in which 100% of people in a community are protected against or can be fully vaccinated. So we know we'll always have some people who are vulnerable in our communities. So when we think about vaccines as a community strategy, what we think about is how do we increase those numbers of green people in my diagram who are fully immunized and therefore create essentially a firewall between the people who are infectious and the people who are vulnerable. And that's when we talk about herd immunity or community immunity. That's really what we're going after, is not necessarily like how do I protect myself, but also how am I a part of creating buffers and safety for the people who are vulnerable and can't make different choices. When we talk about herd immunity, we tend to think about it as all one thing, and we talk about it like it's all one thing. But I think it's always worth highlighting that the level of herd immunity really varies by the disease we're talking about. And that from parents' experiences, increasingly, parents see each vaccine as a different decision, whereas the vaccine narrative asked us to see them all as equally important. And so when we think about what this herd immunity question looks like, we look at the R naught factor. How many people would we expect one infected person to be able to infect as they move through the world? And the more contagious an illness is, the higher we need that threshold number of herd immunity to be, because that R naught factor is so much bigger. So when we get to something like measles, which is considered one of the most infectious viruses in history, we know that a single infected person can infect up to 12 to 18 vulnerable people in a community. Because that virus is airborne, it can stay in the air for hours after the infected person has left the room. And we know that that really changes that herd immunity level. If it's an illness that requires much closer contact, that herd immunity level that we can achieve can be lower because you have to be so much closer to the person to infect them, and therefore we know that buffer level is a little bit lower. So when we think about our public health targets, we can think about the way these shift depending on what we're looking at. Now, I think it's also, as we talk about increasing rates of vaccine hesitancy, we should remind ourselves that most Americans think vaccines are safe and important and should be required. And this is survey data from February 2026. But in general, when asked, should the government require children to be vaccinated to attend school, we know that at least 74% of all adults agree with that. And that we know when people are asked, are vaccines for diseases like measles and mumps safe for children? 84% of people felt certain that they were. And you can see that we have some partisan divides in how much that consensus is, but it's a majority across all groups. And I think that's worth highlighting that we have more agreement than disagreement. Now, what's changed and I've been studying vaccines for going on 20 years. And so the conversation in many ways is the same and in a couple ways is different. And one of the ways it's really different is how partisan vaccine decision making has become in our conversations. So I find this really helpful because this is comparing data from just before COVID and just after COVID. And I think it highlights the way that COVID broke something in our consensus on public health. When I started studying vaccine decision making, there wasn't a huge partisan difference. I heard very similar things from people on the political left, political right. And that's really shifted in key ways. And so people were asked two questions before and after the pandemic. They were asked, parents should be able to decide not to vaccinate their children, even if that creates health risks for other children and adults. And then they were also asked whether they agreed that healthy children should be required to be vaccinated in order to attend public schools because of the potential risk for others when children are not vaccinated. And what you'll see looking at October 2019, which is the lower bar, is that we had higher levels of agreement that children should be required to be immunized. We saw lower support for parents should be able to decide not to. And we really didn't see much of a partisan divide. So if you look at the bottoms with the Democrat or leaning Democrats and Republicans or leaning Republicans, in October 2019, there weren't huge disagreements about this question. And what we see is that those disagreements start to grow significantly as we look to what happened in December 2022, ask those same questions. So we know that something around vaccine consensus really broke down in this time period and that it became partisan and politicized in a way it hadn't been before. And that's important in terms of thinking about how we approach these conversations today. Now, what that has meant is that since COVID, we know vaccine rates have continued to decline. And so this is just looking at, up until the kindergarten survey of the 2020, 24, 25 survey, we can see continuing decline. Now, you'll notice that rates are still pretty high nationwide. So it's not like no one is being immunized, but you'll see pretty quickly that that measles point is below that 95 federal target for herd immunity. And that's where we're starting to see this increasing rates of outbreaks that give us pause and help us recognize that this is a vulnerability in our communities that we should really be thinking through. Now, the other way that this has played out is that the use of legal exemptions within states has increased since COVID. And so, as a reminder, Colorado is a state that allows families to opt out for medical reasons, for religious reasons, and also for personal philosophical reasons. Different states do different things. All but 5 states allow families to opt out for religious reasons, and some add personal or philosophical reasons. But that's really shifted in terms of what opportunities are available for families to still enroll their children in schools or childcare settings, depending on state law, and still be able to opt out of vaccines. And so what you'll see in this chart is this is the number of states who have exemption rates. And if you look at the bottom darkest blue line, over 5%. So we now know that 17 states have exemption rates that are now over 5%. And that's significant because that's people who are filling out the paperwork for exemptions. That's not even including the number of children who are likely under immunized or who are in what we call like non-compliance because they haven't actually done the paperwork. And so that's really important for us thinking about what's happening in terms of capacities through schools and childcare settings. So I think when we start our conversation, we should just talk briefly about what we mean by vaccine hesitance or what we mean by vaccine refusal. And I try to put these on a continuum for you just as a way to kind of think through where people land. There's a handful of people, statistically a small number, who will reject all vaccines. And I've talked to them in the course of my research. I've talked to people who say vaccines don't work, that polio went away by itself and the vaccine got credit for it. We have examples where nothing will be persuasive that vaccines are important, but statistically, it's a really tiny number of people. We also know that there's a number of people who will vaccinate exactly on time, as recommended, on schedule, and will accept everything. But and that's actually not the hugest number either. Before COVID, we knew that 20 to 30% of American parents who were consenting to immunizations were still delaying or spacing or creating vaccine schedules of their own choosing, maybe rejecting some and accepting others, and were reworking federal recommendations in ways that felt truer to them and their experiences as parents and their thoughts about their children. And 20 to 30% of American parents prior to COVID is not necessarily a fringe position anymore, right? So that tells us that there's a huge number of people sort of somewhere on that middle section of this continuum. They're not opposed to vaccines, but they are feeling like the way they were recommended might not have resonated with the way they thought they were necessary, and that they felt that they needed to personally come up with their own strategies. And then since COVID, have been thinking a lot about this category of what I've been thinking about is vaccine indifference. I was surprised how often I met people working at vaccine clinics during COVID who were just, they didn't care either way. They were unmotivated. So if the vaccines were easy to get, available, they might consent to it. If it required taking a day off of work, traveling great distances, they might just skip it. And we should think more critically. I think we assume everyone feels very strongly going into these conversations that everyone's as passionate about it on one way or the other as we may be. And in fact, we know that there's like a number of people where it's not just lack of access, but it's also lack of motivation. And I think we can think about what that looks like as well as we think about how we do our work. So in terms of thinking about this, I think it's really important to, that for those of us who feel that vaccines are safe, effective, and have a proven track record, it's really hard to understand hesitancy. It's easy to think that this is just a byproduct of misinformation or confusion or ignorance. That more health literacy, if we give them more facts, they'll make better decisions would be the solution, which is actually I find untrue. And instead, what I want to suggest to you then, as we talk, is that this is really emerging from cultural pressures and expectations that parents face every day, and that in many ways, vaccine hesitancy is a really logical outcome to the cultural imperatives we put before parents. So thinking about what that means, I mean cultural expectations in terms of how do we define what it means to be a good parent, what leads parents to want to make what feels like an informed decision? How do we hold collectively parents accountable for their own children's well-being, but not necessarily the outcomes for other children? And how do all of these sort of cultural threads that set priorities and values start to shape how parents make vaccine and other healthcare decisions? So the first sort of cultural thread I think a lot about in my research is really thinking about the ways we've individualized responsibility for health. We spend a lot of time encouraging families, and actually everybody, not even families, parents, individuals, young adults, children, everybody to take individual responsibility for their health. We communicate broadly that health is a personal accomplishment, that you should count your calories, you should count your steps, that if you have a health issue, it's probably because you did something wrong. And we think of the health as really an individual accomplishment and also responsibility. And the challenge with that is that, of course, it's scientifically untrue. A lot of diseases beyond individual control. You can do lots of things right, and you still are living with some combination of genetics, environmental factors, and bad luck. But the rhetoric of individual responsibility is really powerful. And we define sort of good health consumers as people who take these responsibilities really seriously. And I'd say during the current federal leadership around the MAHA movement, that vocabulary has even increased in terms of this personal responsibility over community level imperatives. We've done something really similar about parenting. We've really translated good parenting into a series of choices. When we think about school choice, that's really a system of allocating school spots based on the premise that it's okay some kids have a bad school as long as you can opt out of it and don't have to send your kids to that school, rather than making sure all children have high quality education. We could think about car seats, we can think about investments, we could think about the ways that parenting is really translated to investments in your individual child and also informed consumer decisions. And so from these two perspectives, it's actually pretty reasonable then that parents are encountering vaccines as a kind of individual choice that they are uniquely qualified to make. And I saw some survey data this morning that showed about half of parents think they are the best able to make this decision. And so unsurprisingly, parents see themselves as experts on their own children, and they see themselves as best able to decide about vaccines, as well as nutrition and schooling and other kinds of decisions. And vaccines are not in isolation from other decisions. They are one decision on a broad landscape of decisions parents are asked to make every day. I should highlight too that when I looked at parenting books historically, the rhetoric that you are an expert on your own child, that you should trust your intuition, that you should do your quote unquote own research has been embedded in parenting advice books since the 1970s. That Dr. Spock has great paragraphs about how important maternal instinct is. And so in many ways, it's not that parents aren't following expert advice, but in fact, they've embraced a lot of expert advice and used it in ways that were not necessarily what was envisioned at the time. So, as parents make decisions about vaccines, which is what we're talking about today, they really are weighing a range of kinds of decisions. They're thinking about how safe, and these are, I should say, perceived, right? This is not mathematical. This is not risk calculations in the way we can calculate risks and benefits mathematically. This is about perceptions of benefits and risks. And we know that parents are likely to overestimate the risk of a vaccine and underestimate the benefit. That's important to acknowledge, but from their own lived experience and their own perceptions. They are working to evaluate how safe they believe the vaccine is. What is the likelihood of infection? How serious do they think that infection would be should their child encounter it? How well do they think this individual child will, quote, handle the vaccine? And I heard this a lot, which we'll talk more about. How long does protection last? And is it worth that risk then? Do I trust the process of how the vaccine got to market, how it's been tested, how it's been regulated? And then how does this vaccine align with my other family goals, beliefs, and values? So just thinking a little bit about this, and I apologize since I'm taking your lunch break with like pictures of infectious disease, but when we think about evaluating benefit of each vaccine, the vaccine narrative asks us to think about all vaccines as equally safe and equally effective. And what I learned from parents is that they don't see vaccines that way. When they think about the likelihood of infection, they weigh that against the severity of disease. And so they may think of a vaccine preventable disease that's very rare, that's very serious, as worth getting a vaccine against. So polio might be one of those things. But they may think of something like chickenpox, which many parents today remember having as children, as not very important. And so weighing this kind of likelihood of infection and this severity of disease is really powerful for how they think about each individual vaccine differently. I heard parents frequently talk about the ways they estimate what they perceive to be the risks of vaccines. Overwhelmingly, what I heard was that children get too many vaccines too soon in life, too much too soon. But families also look to their family history. They look to their siblings, children, and other children in their family to see how they fared. Did they have a fever? Did they seem to have an adverse reaction? And they saw each child in their family as unique. And I met families who had entirely different vaccine strategies for each child in their home based on this perception of each child's needs. So thinking a little bit about this too much too soon. The top schedule is the vaccine ACIP recommended schedule. And that was, I think, what year did I put this as? 1994. And the bottom schedule was I think, 2024 schedule. And you'll notice there's a lot more vaccines on the bottom schedule than the top schedule. Now, if you believe the vaccine science is really strong, you would look at the bottom schedule and think it's miraculous that we can do so many more things to protect children against so many other diseases. If you're afraid that vaccines could trigger the immune system in some way that feels unsafe, and it might be diffuse, it might be I was asked questions like, how do you know acting on the immune system won't cause an autoimmune disease in 30 years from now? Because we do know there's rising rates of autoimmune disease, and how do we explain that? How do you know for sure, right, what these things are going to do? And if I can't know, isn't it safer to opt out than opt in? Isn't omission safer than commission? Isn't that what good parents do? Is they're cautious? And so from that perspective, that feels really safe. Now, I asked, talking to vaccine researchers, and I've asked about some of the differences. And it's the really clear story that the manufacturing process of vaccines in recent years with better technology, there's actually fewer proteins in every vaccine than there was in 1994. There are fewer proteins in the bottom schedule than there were in one polio vaccine because the filtration and manufacturing is so much more precise. The ability to isolate proteins is so much better. And so that can be really powerful. But from a parent's perspective, if you're worried, you may start to parse out this schedule to make it something different. As parents think about each child too, they also were inclined to think about what vaccines do girls need versus boys? Maybe each child doesn't need the same schedule. And if you think of vaccines as a technology for personal benefit, that's actually not an anti-scientific perspective to say, I don't think my son needs a rubella vaccine because he's never going to be pregnant. But in fact, from a community perspective, we know that many boys and men are around pregnant people and that they are possibly routes of infection. And that's really important. So thinking about it's not necessarily anti-scientific, but it might really be prioritizing that personal benefit over community strategies. Parents also felt that they could control a lot of the risks of vaccines themselves, and this came through individual parenting practices, breastfeeding, nutrition, working hard, controlling social context, the ways they felt they could personally control it. Again, we can say most viruses don't care about breastfeeding. While breastfeeding is really powerful for conferring immunity against viruses people are encountering while they're breastfeeding, like common colds, or stomach bugs, they're not great. My polio vaccine is not conferred through breast milk. That's not anti. They're adopting messaging that comes from public health and applying it in ways that aren't quite right, but doing so in ways that they feel make them good parents, and that's really important to keep track of. So at the end, what I heard over and over again, and I want to kind of build on this, is if we think of parents as approaching vaccine decisions as a personal choice for personal benefit, it's really hard sell to tell them that they are in some way placing other people's families at risk, and to say that they should be doing more for the community. And so thinking about how do we frame vaccines, and this is not just parents, this is how the vaccines are often marketed as personal benefit. How might we think about the ways we then approach these conversations? Particularly then if it allows to say that people who become sick must have done something wrong, and that's why they have cancer, or that's why they got sick, or that's why they had a worse outcome of measles infection. If we accept this personal responsibility frame, that logic becomes sort of, I think, self-evident, and that's where I think we engage these conversations. I think it's worth acknowledging this logic is widely accepted, even amongst adults. This is not a fringe position, and I was very fascinated by this shingles ad campaign that was really going after health promotion as not good enough for infectious disease. And so you'll see, like, I logged 10,000 steps today. I have a healthy diet. I've cut back on sugar and trans fats. And the punchline was always shingles doesn't care, right? Viruses really don't care. And that's really important as we think about this. And there's confusing messaging right now. Now, part of the title of today's talk was about doing this in 2026. And I admit this feels like a moving target every day. And I am constantly looking at new data and new conversations every day to keep up. But just as a quick overview, and I know Dr. Higgins did a great job with this last month and talking about different pieces of this. But when we think about what happened, where we are federally, as you might remember, um, all 17 members of the Advisory Committee on Immunization Practices were fired in June 2025. They were replaced with 13 members through a process that did not follow federal guidance for vetting. They did change, the vaccine schedule was announced to be changed to follow that of Denmark's, which is the lowest number of vaccines of any global north country. And there was a lawsuit filed by the American Academy of Pediatrics, along with several other organizations and individuals. And the outcome of that in March 2026 was that there was a stay. So what we do know is that all the policy changes since June 2025 have been placed on hold pending a larger court review. So there's a stay, which is like a hold while we consider this. So essentially, the vaccine schedules we had prior to June 2025 is again the vaccine schedule. So we are no longer following Denmark. Those ACIP members have been removed, and now there's sort of this moment where we're kind of waiting to see which direction we're going and what might happen. If you are inside baseball on all of these laws and policies, this feels like a victory. And also, most parents are not paying that much attention to what's happening. And so, despite the fact that the court said that only 6 of the 15 had vaccine related experience, that there were limitations with the new members, that ACIP is a really key organization that's been around since 1964, like most parents are just trying to live their lives. And so, this is not what they're paying attention to. But what we do know is that the chaos is harming confidence in public institutions and in vaccine. So, in January of 2026, Kaiser Family Foundation's polling data suggests that about less than half of US adults are confident that federal agencies can make recommendations on childhood vaccines. So it doesn't matter if they know where we are with this, there's a loss of confidence of where to get clear information. We also know that confusion is making parents more reliant on their own judgment and a range of other sources. And I thought this was really fascinating to think about. This is from August 2025. And it asks, how easy is it to know what advice to trust from health influencers and other sources? And what we find actually in these polls that I think is really interesting is a huge number of parents are saying it's really hard to differentiate what's reliable and unreliable information. And all of that's to say that if parents feel responsible for making their own decisions for their children's healthcare, to gather information that feels true, to make what feels like an informed decision, which we communicate all the time as a hallmark of good healthcare consumerism, it's really hard. There is so much confusion from official sources, from unofficial sources, from online sources, it's really hard for parents to navigate this. And we're seeing that show up in decision making. We know also that vaccines and infectious diseases are not the thing parents are most worried about right now because a lot of other things feel more pressing. So, when asked what was their biggest threats that parents saw, and again, this is from last summer, from August 2025, you'll see vaccines, preventable diseases, or infectious diseases are on the very bottom next to fluoride and water supplies of things parents are worried about, but they are worried about social media. They're worried about their children's mental health and anxiety. They're worried about gun violence, right? They're worried about a range of other things that feel more pressing than infectious disease. And although we all spend time thinking about infectious disease all the time, most people are just trying to get through their days and take care of their families. We also know that in terms of the questions that families are really struggling with and what feels most stressful to them, healthcare is a huge problem. That when asked, how worried are you about being able to afford key things for your family? 66% of Americans are somewhat or very worried about affording healthcare. So even thinking about the vaccine in isolation, this is embedded in a range of other stresses families are navigating. So as we consider parents' priorities, their concerns, their competing demands, now we go back to those initial list of questions, and I've pulled out a few of them to focus on. How safe do they think the vaccine is? What's the likelihood and seriousness of infection? How long does protection last? And how does this align with their goals? So let's talk specifically about some vaccines. Um, Sarah said that HPV comes up a lot, and I'm really glad to see that there's going to be a whole day on it. HPV, I think, is fascinating. I've been sort of studying it and writing about it since it was first licensed in 2006, and I think there's a lot of ways that we talk about it without precision. As a quick reminder, HPV vaccines prevent against genital warts, and HPV cause cancers. It's most effective when given before infection. Even if you are vaccinated against HPV, you probably still need screening. But as a reminder, the treatments for cervical dysplasias can be really painful and terrible, and those become less common over time. And so those benefits are significant. What's important to thinking about vaccines is that this is the share of adolescents who have had at least one HPV vaccine by insurance status. And so the black line is Medicaid at the very top, and then the green line is uninsured at the very bottom, and the purple line is the US overall rate. So it turns out public insurance actually looks like it has some advantages to getting access and private insurance falls, but we know there's a large number of people who are uninsured and who don't have access, and that is shaping significantly their protection against HPV. In terms of families' concerns, when we started talking about HPV when it first came out, there was a lot of attention about the ways it was seen as sexually transmissible, and therefore parents didn't want it because they didn't see their children as sexually active. And as there's good evidence that getting the vaccine earlier is really important, which I'll show you in a second, for protection, it seems crazy that you would vaccinate a 9-year-old against a sexually transmitted disease. Now, I think that's really important to say, the question of longevity of protection became really confusing during COVID, right? That we weren't clear initially how long protection against from COVID vaccines would last. People began creating their own strategies, like I'm going to get immunized 4 to 8 weeks before a big wedding or before a big vacation so I could maximize my protection, right? There became this kind of customized personal strategy of vaccines based on the sense of longevity. And we forget sometimes that as we talk about vaccines as all the same, that question of longevity is really important to people as they think about the timing of vaccines. Sometimes they want the protection, they just think it's too early. And did I get my flu vaccine too early? Did I get this? And that's true for some vaccines, but not all. And talking through that can be really important. And so it turns out like long-term studies show at least 12 years of protection for HPV vaccines, and there's still no boosters recommended. Um, Initially, the vaccine was only licensed for girls and was really talked about in terms of cervical cancer and the ad campaigns of, I don't know if you remember, like the one less, I want to be one less, which I guess technically should have been one fewer, and when Merck gets their grammar right. But with these kinds of like good moms prevent cancer, right? We talked about it in very gendered ways. That made it really hard when boys became eligible for the vaccines. What's really significant that I don't think we talk enough about is that boys may benefit as much or more than girls now. And so at the bottom is just some really brief um, cancer-related data from 2021 from the CDC. And what you'll see is actually the blue is oropharynx, so mouth, throat cancers, and that boys and men are experiencing these at huge numbers. And in many ways, as girls have greater protection, we're seeing rates of cervical cancer go down significantly, but rates of head, neck, and throat cancers going up for boys and men. And unlike a cervical cancer, which a pap smear is likely to detect, Head, neck, and throat cancers don't have a primary lesion. So they're really hard to screen for, and they're often not identified until they've advanced. So when we think about vaccine protection, it's pretty interesting to look at how earlier immunization is actually creating better protection. And so looking at cancer incidences of cervical cancers per 100,000, you can see that very low dotted green line are people who are immunized at younger ages. And that's really significant. So we know the recommendations currently are that if you were between the ages of 9 and 14, you only need 2 doses of an HPV vaccine because you build a stronger immune response. And that's different than if you're over, that as you get older, you need different kinds of dosing, an extra dose to ensure protection. And that's significant to sort of talk through as parents think about their strategies and what they're protecting against. We know that HPV cancers affect young people and that that's significant when we think about the age of diagnosis of cancers as well. So they might say, like, why am I vaccinating now for something that they're not going to see till they're 60? It turns out we're seeing different kinds of cancers emerging at different ages. And so this is a decision parents can make early that could protect their kids long term against a range of cancers. And that could be really motivating. Um, Before I jump to thinking about, HPV cancers, I think they are becoming decoupled from thinking about sex. And we sometimes, forget to communicate that you can contract HPV viruses without penetration, that sex is not necessary for transmission and that rates in the community are relatively high. And so even in those conversations about how children are protected now versus later, this can be a powerful tool, but it doesn't force them to acknowledge their children will be having sex with people who have been sexually active with others. Like that doesn't have to be the conversation in terms of thinking about what their benefits, the benefits and decisions are. To say a few words about measles, because we talk about measles a lot. To give you just a quick sense of it, in 2025, there was almost 2,300 cases nationwide, 35 confirmed in Colorado. As of April 9th, so this last week, there were a little over 1,700 confirmed cases nationally, about 15 in Colorado. By all measures, we are on track to exceed the 2025 numbers by quite a bit at the rate we're going. Measles is most dangerous for very young children, and the vaccine is relatively it's not particularly effective in children under the age of 1, who are the most vulnerable to the worst outcomes of infection. So measles vaccines are a really powerful tool for protecting babies and toddlers in ways that we don't always talk about. Infection was ubiquitous, and there's lots of examples of people who've had it and they recovered, and that's great. But about 1 in 5 children who are infected will be hospitalized. And pneumonia is the leading complication that leads to death in young children. And so, if you followed the cases in West Texas and the 2 children who died there, there's like an insistence that they died of pneumonia, not of measles, and therefore it was the fault of the hospital for not treating measles correctly or treating pneumonia correctly but in fact, right, the pneumonia results from the measles infection. Lesser known things we don't really talk about that I think are really compelling. Measles infection, even in cases where people recover, is estimated to wipe out between 11 and 73% of existing antibodies from prior infections. And so this kind of causing immune amnesia, to lose infection protections against prior encountered viruses, is actually a significant kind of complication that doesn't get measured as a complication of measles per se if people were to encounter other illnesses, but in fact is really significant in terms of long-term risk. There's a much rarer risk. SSPE is a progressive brain disorder. It shows up between 2 and 10 or more years after measles infection, often after a child is fully recovered. It's untreatable and fatal in almost 100% of cases. There was a child who died this year in California who had recovered from measles at the age of 2 and then began having this kind of neurologically degenerative illness until he passed away this year. And so it's rare. I think estimates are 1 in 10,000 cases, but it's a significant kind of complication. And I think it's just a reminder that in a range of ways that both measles and HPV speak to, but other viruses do as well, viruses can mess with you for decades after you've recovered. Post-polio syndrome is measurable, right? We know that even recovering from an initial infection can still have long-term outcomes that are significant. Shingles is another, right? So we sometimes think about infections as short-lived, and parents often say to me, well, once they recover, they'll have lifelong immunity. That'll be great. And what measles amnesia suggests, but also what a range of other health conditions suggest, is that recovery doesn't mean you're healthy, and that can lead to other kinds of health challenges over time. In thinking about the rest of the MMR, which we don't really talk because measles is like so obviously the important one, but rubella is a mild illness. So if we think about rubella as a vaccine for personal benefit, there's not a lot of benefit for most people. It was a mild illness. Looked like a bad cold. You usually recovered pretty quickly, but when women were exposed early in pregnancy, it led to congenital rubella syndrome, which was a range of birth defects, and it was the leading cause of congenital deafness in the United States prior to vaccination. So rubella is most clearly a vaccine for community benefit. Young children are frequently around pregnant people, and that's really important in terms of thinking about what this is, even if it's not for personal benefit, even if it's a person who's never going to become pregnant. And then mumps is the third component of it. Mumps also tends to not be as serious of an illness, although it's a very uncomfortable illness, um, but can lead to, in cases of brain inflammation and other complications. The MMR became combined in 1971. There's some evidence that by combining it, there's a better immune response when given together than separately. Last year, President Trump and Secretary Kennedy suggested that these components should be given separately. They have not been manufactured separately since 2011. It would take roughly 3 years to retool our manufacturing, and there's no scientific basis for doing so. Additionally, most people and most of the world market don't want children to have 3 injections when they could have one. But that rhetoric that this is too much too soon has played out in ways that leaders are pointing to. When we think about other vaccines, I think a lot of the same tools about where are parents coming from and how do we connect are really key. So parents may delay vaccines because it feels safer, but in fact, actually delays may increase the risk of some adverse reactions, including fevers. As children's immune systems are more sophisticated, they're actually more likely to have a reaction, which is pretty interesting. We sometimes forget that vaccine preventable diseases, even if you fully recover, are miserable. Being sick is pretty miserable. Some of the parent accounts of what measles is like have been sort of terrible to read and hear, and that children have been really struggling with their vision, with fevers, and with a range of kinds of symptoms. We've also don't sometimes talk to families about what would it mean to take time off for you? Who would take care of your child? Um, what would happen for a hospitalization? And I recently wrote a piece in the New York Times about our lack of pediatric hospital capacity in the US, how we've lost roughly 40% of hospital beds since 2008. We know many families live very far from a hospital prepared to treat children, and that hospitals are frequently at capacity. We also know hospitalizations are really expensive, and as parents and families think about their struggles with other kinds of costs, healthcare and hospitalization costs are significant. Um, we should acknowledge that some immunity is short-lived and others is long, but that's not necessarily a vaccine failure. And I think one of the failures of messaging during COVID was that even if immunity wanes, not dying of an infectious disease is a benefit of a vaccine. Even if you're infected, but you don't get as seriously ill that's a benefit of a vaccine. And we haven't communicated that kind of nuance. And so if people are expecting sterilizing immunity as they do with measles for all respiratory illnesses, we don't have respiratory illnesses that offer that, but they still offer other kinds of protections. And I think being straightforward can be really powerful in managing family expectations. Not all vaccines are for personal benefit. Some are and some aren't. And I think we should be forthright about why we do them and what that means, and where they're really important and where there's long-term, trade-offs in terms of what it means for the community. I wanted just to like bring up the issue of vitamin K, which is not an infectious disease. It is a newborn intervention that's been offered and recommended since 1961. And I wanted to highlight it for the following reason. On I guess the right side of your screen is a post from many anti-vaccine blogs and websites pointing out that vitamin K is so dangerous that it has a black box warning issued by the FDA. And I hear from pediatricians that this is brought up frequently in decisions to reject vitamin K. Vitamin K, as a reminder, is given in the US through subcutaneous injection of infants to prevent a very rare but often fatal brain bleed or bleeding disorder. Estimates are that it's a small number of babies who are susceptible to it, but if they have it without vitamin K, they're 81 more times more likely to develop brain bleeds between 1 week and 6 months after birth. And that we know that refusals have increased significantly, and that that's sort of raising new issues. And you can look in the media, there's examples of babies who have been dying in the last couple of years of vitamin K deficiency. So if a family comes to you and says, like, I don't want vitamin K because there's a black box warning from the FDA that this causes severe anaphylaxis. Why would you ask me to do this? The first reaction is like, that's stupid. That's untrue, right? Like it feels, and to dismiss it. It's an interesting strategy to say, you're correct. That is a black box warning. And this is who it applies to. It applies to adults who have received it intramuscularly or intravenously, particularly when it's rapidly administered to reverse anticoagulants. It has never been demonstrated in infants. And then to highlight, like, what a good mother you are that you went and read this and you found this and you're concerned and let's talk it. What does it mean to acknowledge, like, you found this information that's true? Let's add some context rather than to dismiss it out of hand. And when I was looking, I found a lot of examples of let's just dismiss this as wrong, as misinformation, without really acknowledging that there's kernels of truth in these concerns and we can start from those perspectives. So as we think about kind of where to wrap up with this, I think that there's no single key to how to do this kind of work. Families are bringing in their own experiences with institutions, and that could be healthcare institutions, it could be legal institutions, it could be their sense of alienation from applying for Medicaid, it could be their experiences in traffic court, right? How do they think about the state? How do they think about the government? How do they have confidence in the neutrality of the scientific process as they've understood it? We have to remember, like I showed you, talking about exemption rates at a statewide level, we forget that families are engaging local norms and that vaccine hesitancy clusters. So very few people live in a community with the state level of kindergarten immunizations, but they live in pockets that might have higher or lower rates. And Immunize Colorado shares that information. Our state laws allow us to look at a school by school basis, which is pretty interesting. But knowing what the values are where you live is influential. We know that families who move into vaccine critical schools are more likely to become vaccine critical themselves. And that's unsurprising. Parents share information about what summer camp to sign up for, what soccer camp to do, what teacher to request next year. And this is another way they look to engage the norms in their space. We know that though having convenience of access is really important, that families are encountering competing expert information, and that throughout parents really want to be good parents. What we do know is that conversations that are not helpful, giving a statistics heavy approach, like I gave you these rates, but families really don't care about the rate because at the end of the day, their child is an N of one. They are 100% of the experience. And so knowing the statistical probability doesn't help them estimate the probability for their child. And I frequently heard families saying, I don't think those apply to me in my house with my lifestyle, with my nutrition. And so statistics don't help. Fear-based approaches don't help. Telling them terrifying, showing them terrible photos, fear-based doesn't help, and it often can make things worse. Correcting and challenging information as wrong may actually make people more entrenched in those beliefs. And we know that incentives and lotteries don't actually help and may mistakenly assign a monetary value to something that shouldn't be monetized, but actually has like a value-based health promoting value to it. What could help is leading with empathy, which helps in healthcare in general. Being open to ongoing discussions is really challenging and important. Many parents in my interviews have said that they don't think of vaccines as a one and done decision. They see this as a decision they revisit as their circumstances and lifestyles change. Their child wants to study abroad or become a missionary. Something in their family healthcare, their child has leukemia, they now get flu vaccine. Like things change and they revisit these strategies over time. Identifying structural barriers to access can be really important, especially for people who are not particularly motivated to overcome a huge number of barriers. School-based resources are really important when schools bring things up and make them easy. Families engage better. Having access to people in their communities they trust to talk to can be really important. And then I think we always have to circle back to these family goals, right? Like maybe my goal is to make sure that my relative who had a kidney transplant is safe and I don't bring illness home. That's part of our family values that I can align around these questions. How can I protect people I care about? Those might be part of my values. We can discuss and build these as sort of a strengths-based perspective. And I think that the motivational interviewing training that's coming up is also really helpful in thinking about this space and thinking about these in terms of community goals too. How you understand their discomfort and fear is really important. How you understand their barriers to access, are important. You're the expert on healthcare, but I think it's important to acknowledge that parents are experts on their own lives. And our goal collectively is to empower families to make decisions, not to proselytize or convince them, but to give them the information they need to feel like they are in charge of this decision, which is really important to their sense of themselves as good parents and to meet them where they are. Now, having said all of that, you get to decide what you do with this information, and you get to decide what you do when you've shared everything you know as empathetically as possible and they still don't want vaccines and they still don't agree. Um, Individual providers in your context have to decide how you want to balance this within a practice setting. I've spoken with physicians who know babies got whooping cough in their waiting room, and that they have made different decisions around their practices. So thinking about what's important to you, what's the possible risk to your other patients. Do you have confidence that you can support their children's health in other ways beyond vaccines with developmental screens and other social supports? But in the end, like as a provider, you also have to be true to your values. And I think thinking about how we connect those is really important. And so just to wrap up, I would, leave you with a couple thoughts. One is that it's too easy to dismiss individuals who question vaccines as ignorant or anti-science. And I think that's not a useful place to start, and I don't even think it's accurate. Instead, we can think about the way these cultural threads that define what it means to be a good parent and a good health consumer are stronger and longer than this moment. And they're not just about vaccines. They're about a range of other parenting decisions. And vaccines don't live in isolation from all of these other concerns parents are dealing with. We can make the benefits of vaccines, including the risks of not being vaccinated, clearer, and make it relevant to families. And we can hear specific concerns, acknowledging that they may draw on their personal experiences, their family's experiences, their political or religious views, or concerns about a particular child who has eczema or who seems to have allergies, and therefore I'm worried about their immune system not operating correctly. Like, how can we engage that conversation? And I think I'm increasingly focused on the way that we all want healthy children in communities, and that there's spaces where we actually have more in common. We're not as far apart as we think, and that there's opportunities, I think, to re-engage, granting people self-autonomy, but also connecting to the ways we have shared values. And I'm going to stop there, so I have a couple minutes to answer any questions you might have.
Thank you so much, Dr. Reich. I have to say, I really liked your use of the word curiosity on one of those last slides. I think that's a really good thing to keep in mind as we're talking with parents, because as you said, there's a lot of different reasons why folks might have questions about vaccines. Speaking of questions, now is the time for Q&A. So if you have questions, please put them in the Q&A box. We do have a couple. So first is just, it sounded like you were discussing parents generally, but at least some of what you were describing seems like it would be more of an issue among more privileged parents or those who have better access to healthcare, and more time to come for more visits if they were to spread out the schedule. Is this true, or is it just an impression? If it's false, how does that work in practice for the less privileged parents? And if it's true, how would you break down groups of parents who face different challenges?
Yeah, this is really great. And when I talk about some of the things that have changed since I started studying vaccines, when I started studying vaccine hesitancy, we had really good epidemiological data to suggest that the parents who were most likely to opt out of vaccines by choice were white, with at least some college education and higher family incomes on average. That really shifted during COVID. And it's unsurprising because we know that cultural themes sort of disseminate downwards, socioeconomically, right? We know that the values that have been embedded in what's being called the Maha movement, right, have really focused on these kinds of individual practices. And that's increasingly as people are seeing themselves as good parents or really engaged around questions of their children's health, right? So we know that that's shifting. The capacity to solve some of these problems, though, are significantly different. I think a lot about what does it mean if you say, I'm just going to exercise an exemption in Colorado because I can, and then your child's school has a 21-day quarantine because of a measles outbreak? What does it mean to not be able to go to work for 21 days potentially? What does it mean that if you get sick, who's going to take care of your family? Like, thinking about these things are embedded, and that's where resources can really make a difference. And I think those are spaces of conversation for families too, to say, like, how do we balance your concerns, your lack of, and some of this is just, I don't know what's safe. And so doing nothing feels safer is like a really serious space we live in right now. And I went looking for hours yesterday for like current HPV vaccine data, and the CDC is not collecting any right now. So we don't have any. And this is all I do full time, and I can't find what I need. And how are average parents who are working full time and managing their kids' lives doing this? And I feel a lot of empathy for what that feels like, because we make parenting decisions really high stakes. We make like, I think pregnant women are or when mothers of children with disabilities are asked all the time what they did wrong during pregnancy that could have led to their child's disability, right? We individualize these things in clinical encounters even all the time. So unsurprisingly, all decisions feel really high stakes, and mothers carry the biggest burden. We know mothers make most of the healthcare decisions, and they carry most of the responsibility and blame as well.
Great, thank you. And yeah, very complex ecosystem that we're dealing with here. We had a question come through the chat. First, they said this was a fantastic presentation, fantastic in all caps. Question is, how do you address the correlation versus causation discussion, i.e., this symptom happened after this child got a vaccine?
Yeah, this is a really important one. And I always like to highlight the ways that like the parents who reject vaccines and those of us who are, study vaccines sometimes do the same things, right? So, I mean, I like to highlight that none of us live evidence-based lives. None of us do best practices every day of our lives. None of us as parents, I think, live the American Academy of Pediatrics guidance every day, all day, right? We can all acknowledge that. And so, thinking about coming to this with, I think, some humility. Is really important. The correlation versus causation arguments are really interesting. And I was surprised by some recent polling data, I think from March, that suggested that a sizable number of American parents don't think we know about the relationship between vaccines and autism, which I think has been studied better than almost anything in history. And the idea that we don't know is really interesting, right? So, this correlation versus causation often starts from this space of like, maybe it's not known, maybe it's not knowable, maybe no one's looking. And some things we do know. There are things we have studied. Like actually, it turns out Denmark has done a ton of vaccine research on autism and has given us some really good indications. Since we look at Denmark for other things, we should look at that as well. But I think these questions are really hard and worth pursuing. I also think that families can mostly handle uncertainty. And I was worried a lot. I looked back at things I talked about during COVID in this area and how many times I said overpromising will be a mistake. Overpromising results will make people feel betrayed if it's wrong. But I think we can say, here's what we know now. And here's what we're continuing to learn. I think we can do that sometimes. And so the correlation versus causation, we can acknowledge with the best information we have right now, this is what I think we can do. And this is how I made a decision. This is how I weigh information in my life, right? And some things, again, some parents are unpersuadable, but I think asking that kind of starting with that curiosity of like, what is it? What relationship are you thinking about? How do we understand rising rates of autism as not related to vaccines? Like, okay, so we know, but to say they're not going up, or autoimmune, we know autoimmune diseases are going up. And we also know that they started going up around when we started using more vaccines. How do you know they're not related, right? We can talk through that. We have good answers to that. But I think dismissing it out of hand is always where we sort of close off the opportunities to continue to engage in this space.
Thank you. And we've had a lot of great questions coming in. I'm having a hard time
Yeah.
choosing what to ask. But I think we'll go with, how do you culturally acknowledge vaccine hesitancy for families that might be coming from other countries or who are not familiar with the US schedule?
Yeah, I love this. And I think like this sort of question of like where are people coming from is really important. I think there's been like some really interesting evaluations of, for example, immigrant communities who have high levels of distrust, who have also been pockets of measles outbreaks historically, whether it's Ukrainians in Seattle or Somalis in Minneapolis, or like thinking of these cultural pockets. And a lot of time they're drawing from their relationship to the government. Um, that the relationship to being their experiences of being over immunized in the process of immigrating, or we know that families are often over immunized while they're in refugee resettlement areas, right? So like taking seriously their lived experience of this and really bridging towards how it could be similar or different here. I do think there's also a space that we tend to think about back to that vaccine narrative that all vaccines are important. But I've talked to a lot of providers who are developing strategies around particular things about like this one's non-negotiable. Like this one will kill you before we can diagnose it. Let's talk about this one. This one we can revisit in a year or two, right? Like starting to kind of do this work with families to really show that you're taking their concerns seriously. Again, it has to be value aligned with who you are as a provider, but there's opportunities to really create some space where you keep coming back to the conversation. And this isn't quite what you asked, Sarah, but I think it's also like when parents refuse, we just assume it's done. And like no one wants to revisit these controversial conversations, but in fact, leaving the door open and just checking in again regularly, and I've heard providers say that they've had success just saying like, I'm going to ask you again in 6 months, just so we can make sure we're checking in regularly and acknowledging that's what we're going to do. Not that I'm forcing you, but I want to keep the door open can sometimes be really powerful families as they're kind of working through this. And that could be true of families who have moved here and are slowly integrating into different kinds of health systems in our country.
Great. Yeah, thank you. And yeah, we hear, when we're doing these motivational interviewing trainings with folks, we hear a lot of those similar concerns, right? Like not really wanting to bring it up multiple times and all of that. So, well, thank you so much, Dr. Reich. We really appreciate your time today. I am putting up our post-webinar survey QR code on the screen. So if you're still here, please scan the QR code, leave us some feedback. We want to know what you want to know during these challenging times in the vaccine space. So really appreciate everyone coming today. The recording and the slides will be on our website within a week. So if you have any coworkers who may have missed this and want to see it, they'll have an opportunity to. But otherwise, thanks, Dr. Reich. Really appreciate you.
Thanks for having me.